Nerves. Published by WordPress.com. Brachial plexus injury, BPI. Anatomy. The brachial plexus is formed by the anterior primary rami of the C5-T1 spinal nerves. It consists of roots, trunks, divisions, cords, and branches. Variations in the brachial plexus can occur. Prefixed, C4 extra. Postfixed, T2 extra. Key branches. Roots, dorsal scapular nerve, C5, long thoracic nerve, C5, C6, C7. Trunks, suprascapular nerve, C5, nerve to subclavius, C5. Divisions, anterior and posterior divisions of each trunk. Cords, lateral, musculocutaneous nerve, lateral root of median nerve, medial, ulnar nerve, medial cutaneous nerves of the arm and forearm, medial root of median nerve, posterior, axillary nerve, radial nerve. Other branches, upper subscapular nerve, thoracodorsal nerve, lower subscapular nerve, medial pectoral nerve. Etiology and pathophysiology. BPI can be caused by closed injuries, traction, e.g., OBPP, motor vehicle accidents, compression, e.g., clavicle fractures, shoulder dislocations. Open injuries, e.g., sharp lacerations, gunshot wounds, crushing injuries, burns. Parsonage-Turner syndrome, acute neuritis viral or amyotrophic, acute brachialgia. Entrapment neuropathy, thoracic outlet syndrome. Risk factors for OBPP, breech presentation, large for gestational age, forceps delivery, long labor time. Classification of OBPP: obstetric brachial plexus injury. Erb's palsy, upper trunk injury C5-C6, most common, affecting shoulder adduction, elbow extension, biceps weakness, and forearm pronation. Policeman tip position. Klumpke's palsy, lower trunk injury C8-T1, affects intrinsic hand muscles, causing claw hand deformity. Total palsy, involves avulsion of all roots, with a flaccid arm and loss of function in most muscles except the trapezius and some parts of the deltoid. Preganglionic versus postganglionic injury. Preganglionic injury involves the CNS and is more severe with no regeneration potential. Postganglionic injury involves the peripheral nervous system, with a better prognosis and potential for regeneration. Clinical presentation, C.P. History, trauma, labor complications, OBPP, or sudden injury mechanisms. Motor, weakness, muscle wasting, loss of reflexes. Sensory, paresthesia, pain. Deformity, trophic changes such as thin, dry, shiny skin, brittle nails, and abnormal positioning, e.g., shoulder adduction, elbow extension, forearm pronation. Pulse, assessment for vascular compromise. Differentiation, distinguishing preganglionic from postganglionic injury, using tests like the Bunnell test for intrinsic tightness and EMG for nerve function. Imaging. X-ray, to assess clavicle fractures, shoulder dislocations, and any associated bone injuries. MRI, to determine the level and severity of the injury. CT, myelogram, for precise localization of nerve root involvement. NCV, EMG, helps in distinguishing preganglionic from postganglionic injury. Treatment. Conservative. Splindage to prevent overstretching of muscles. Galvanic stimulation and physiotherapy to prevent muscle wasting. Observation and rehabilitation, particularly in less severe injuries. Operative. Nerve repair. In acute injuries, nerve repair with or without grafting, e.g., sural nerve graft. The decision to perform primary nerve repair versus nerve grafting depends on the nerve gap length and the ability to achieve a tension-free repair. General guidelines for nerve gap management. Less than 5 mm can often be repaired primarily with slight mobilization of the nerve ends. 5 to 10 mm may still allow direct repair with nerve mobilization, but tension should be carefully assessed. Greater than 10 mm nerve grafting is typically required to bridge the gap and avoid excessive tension at the repair site. Neurotization, burying nerve end into muscle direct. Nerve transfer. Intraplexal, e.g., Oberlin transfer for upper trunk injuries, or extraplexal, e.g., spinal accessory or intercostal nerve transfers, techniques for restoring function. Reconstruction. Tendon transfer, e.g., in C8T1 injury, free muscle transfer, e.g., gracilis muscle, arthrodesis, and osteotomy in cases of significant deformity or chronic injury. Prognosis. OBPP. Generally, early intervention yields better outcomes, with nerve repair and rehabilitation providing functional recovery. Total injuries or delayed interventions, beyond 6 months, have a worse prognosis, and surgical exploration is often required for severe injuries. Adults. Indications for surgery include gunshot wounds, partial injuries with signs of recovery, e.g., Tinel sign, and open or iatrogenic injuries requiring immediate exploration, within 1 week. Early intervention, 3 to 6 weeks, nerve repair, neurotization, and tendon transfers. Late intervention, 3 to 9 months, for plateau stage injuries, surgical procedures like tendon transfer, free muscle transfer, or arthrodesis may be necessary.